Thank you, and thanks so much for the kind introduction. And real honour to be given this award, and also a real honour to be able to talk to everyone about some of the work that I've been involved in at the Institute over the years. I thought that in putting this together, I might talk a bit about how I came to be at Burnet and just give a little snapshot of the different areas that I've worked in and some of the projects from those areas as well. The first thing, just to emphasize that public health wasn't my first career choice. I grew up sort of wanting to play footy for the Hawks. Very quickly learned that I didn't have the build of a football player and needed a fallback option. So I then had a fallback option, which was to do a PhD in maths. And without going into any details, I spent about 4 years in my PhD proving this theory. So I've thought about it quite a lot, really just different ways to count things. And then after I did a PhD, I had a bit of a change and I went and got a job building models of train networks. And so this was really where I got my first experience as well in data collection, like real world data collection. And I remember having to sit at a whole bunch of train stations around the city, just with a stopwatch measuring how long the trains sat at the platform for before they left, so that I could get a distribution of that to put in the model and run simulations of how chaotic things would get if a passenger would get sick at different times and at different stations around the city. So that was interesting. But then after a while, I was looking for a bit of a change, and Paul Dietz, for some reason, gave me a job at Burnet. And so I came over to Burnet and I've been here since. In the first couple of years while I was at Burnet, I was really looking through the mixed data set. And so there were a lot of analyses, particularly on the purchasing of different substances, the use of them and the prices of them. These graphs kind of show one of the standout studies, I suppose, which was when we were looking at the cost of different drugs, and also this was against a backdrop of harms associated with methamphetamine use in Melbourne had been escalating between 2009 and 2013. And by looking at the patterns of purchase and matching that with some of the purity analyses done by the Victoria Police, we're able to identify that there'd been simultaneously a massive increase in the purity of methamphetamine, as well as the variation in purity of methamphetamine. And so really what was happening was there was this reduction in purity adjusted price, and people were getting more than they bargained for in a lot of cases, and this was driving some of these. And so this work fed into a couple of parliamentary inquiries and was really useful around that time. Another study that I pulled out from this analysis as well, there was a point where they were installing a whole series of CCTV cameras in Footscray. The literature on CCTV cameras is notoriously, no one really knows, and it's kind of weak. But because Paul had this longitudinal data set of people's drug use patterns in Footscray at the time, we were able to do an analysis and see that there was a correlation with when these cameras were installed, and in particular, some of the cameras were stored above public toilet blocks, including those self-cleaning toilets that are around the area. And we were able to identify that there was a correlation with the installation of these cameras and a reduction in drug use in public toilets and an increase in drug use on the street. So really, there's a number of ways to interpret this, but it's quite likely that the CCTV cameras just shifted the drug use, which has many implications. And as you can see, it's got a bit of media here too. Another thing that I recall from this study was just a rejection letter because we had trouble publishing it, and I don't know how many people have had a rejection letter like this, but the editors wouldn't consider the article because they thought it was too short. So they basically told us to go away. We weren't waffling on long enough. So I've held on to that one. Another major component of my work at Burnet, and probably a lot of my work, has been around hepatitis C. And it's been really interesting digging up some of these older studies, particularly these were sort of projections and studies that were done around 2015 and 2016. So really, as the treatments were becoming available or just available. And so it's been 5 years, and it's just interesting looking back at some of the things that we were claiming. So firstly, here's a projection that we made at the time that was looking at a scenario where treatments were not made available and not scaled up. And you can see the different colours indicating different disease stages, and this is the total number of people with Hep C. And running projections then for what a treatment access scenario would look like. And we can compare it to what's actually happened. So in these projections, we're looking at by 2020, having treated about 80,000 people. And that's actually quite close to what has happened in reality. So I think that's an interesting comparison. And also that even then, we're looking at these projections where we get down to a certain point around 2024, 25, where we start to see a flattening off of these treatments. And if I were to cut up this graph a different way, so rather than showing it according to disease stage, if I were to show it according to stage of the care cascade, we see that the issue in these projections was always that there were people undiagnosed or people who had been diagnosed and lost to follow-up that were going to be left over at the end, and that these people were most likely to be people who inject drugs, and we were going to struggle. So I think we've been saying that for a while now, and there's basically an entire EC Australia team that has been working really hard doing a number of different studies, and I mean, their primary goal is to prevent this from happening by finding innovative ways to kind of engage people in care and test more people and educate people. So that sort of pairs in nicely with that work. Hepatitis B is another infectious disease that has I guess a different set of problems. This is some work that was started with Chris Morgan and Margaret, and now Chris Seaman's taken a lot of it up as part of his PhD as well. The problem with hepatitis B, or one of the biggest problems with hepatitis B, is that we've got this vaccine for it that's nearly 100% effective, but it has to be delivered within 24 hours of birth. It has to be stored in a fridge, and it has to be delivered with a needle and syringe. And so these problems combined, we think that a maximum coverage that we're going to be able to get is 65%. So it's just these barriers, these infrastructure barriers and other things. But there are solutions, and the solutions to it are there are ways to bypass the cold chain, and there are ways to deliver it that don't require a needle and syringe. And if we could use those ways and get them licensed and available, then they could go a long way in solving this problem. And not only that, but the analyses show that they would also be cost saving. So not only would they prevent infections, they would save money. So they're a pretty good deal. To change topic again, and focus this time on some resource optimization. There's a large component of modelling work that's been happening over many years in nutrition. So really looking at ways to reduce stunting and wasting among children under 5. There's been a subset of that which has been work conducted in Pakistan. And Pakistan's been a good place to work on nutrition over the last few years because when Imran Khan became the Prime Minister, he stepped in and declared that he was going to reduce stunting. That was what he was going to do. And there was money on the table for doing that. This graph shows on the left, it's sort of what they're currently doing now in terms of their spending allocations. They had this new funding in the purple here, and their intention was to spend the new funding on specialised nutritious foods for pregnant women and for children in the 2 shades of purple. We estimated that could give them an additional 54,000 alive and non-stunted children. The reason that they wanted to spend it on this SNF for pregnant women and children was because it is a really effective intervention. In fact, it's probably in the context the most effective intervention. And so whoever made the decisions probably just said, I've got money, give me the most effective intervention, we're going to do it. But the challenge is it's also one of the most expensive interventions. And so the decision is, do you provide the most expensive intervention to only a few people, or do you provide cheaper, slightly less effective interventions to everybody? And the analysis, when we run the optimization, we look at the same amount of money, and if the same amount of money is spent on a different set of interventions, then you can achieve nearly 4.5 times the impact with the same amount of money. And it's even hard to tell because some of these interventions are just a lot cheaper than the ones. They're just slithers in this graph. And we lost a lot of friends with this. They wanted it to be simple, but it wasn't simple. And really, the World Bank and other organisations have the support of doing this, and they've started piloting this solution now. With the Optima nutrition model, we've also done a lot of trainings. We've been able to go to about 15 different countries now, and we've trained people from the Ministry of Health and Finance in how to use the model to make those kinds of decisions themselves. It's got a web interface. This was one that was done in India. They put on a really nice display for us, and it was quite fun actually. They had about 100 people attend. Of course, now the trainings look a bit different. Here was one from last year, and I got to stay at home. This idea of resource optimization, I won't talk about it for too much longer, but we've really, the team has done great work in resource optimization in a number of areas. So we're the exact same ideas of how do you get the best value out of the best bang for buck. We've done some work in malaria. This is some work from a few years ago in Nigeria that was done with Rowan and Freya, and really asking the question of, if you've got an extra $250 million, what should you do with it? And not just what should you do with it, but where should you spend it? And it won't really surprise anyone that the answer is you should spend the majority of it in the areas that have the highest burden. And there's a cost-effective mix of things that you can go with. I also want to give a big shout out to Cherie and Rowan and Deborah and the team who have done tremendous work in resource optimization over the years, much longer than my time. And here's a slide courtesy of Cherie, really just summarizing the engagement they've had in HIV resource optimization. So these are analyses that they've done in a number of countries, as you can see, quite a number of countries, and not just high level, but actual engagements with governments in those countries as well. So really amazing work by Cherie, Rowan and Deborah. Another area that's a big area of the Institute is the maternal, child and adolescent health program. We've done an increasing amount of work with that team as well. This is a project that came up, and Caroline sort of made the right introductions at a time last year, and we were working with UNFPA to develop an investment case for family planning and maternal health. And we did this for a series of small islands in the Pacific. We also did another one for the Caribbean, so it's not here because I couldn't fit all the names in the title, but there was another version of this as well for the Caribbean. And we expect it'll come out in a nice kind of glossy print by UNFPA fairly soon. One of the things that we were trying to do was quantify the benefits of scaling up services for family planning and maternal health in these settings. And as well as looking at the direct impact of that on health, the purpose was it was an investment case. And so we're really looking at the fact that an investment of about $13 million in these selected countries could give returns of about $150 million. And so that's about an 11-fold return. And this information is really useful in the context of trying to prioritize how health system budgets and things are allocated, because it just shows the kinds of value that you can expect to get from investing. The other immediate reaction to this kind of a study as well, particularly from the UNFPA team, was that $13 million is spare change. We can just fix this problem and let's get DFAT on the line. So I think they'll be leaning on this a bit with a lot of their engagements, and certainly using it for strong advocacy for investment in the space. All right, and the final change of topic, COVID. I think we're probably all a bit sick of it, but it's been a big year for people everywhere. A lot of you have seen this graph already. This was something that the Victoria Department of Health did allow us to release during last year. Really, there's been work from the team. Ramesh and Dom, in particular, Ramesh has been asked to do a whole lot of unreasonable things over the last 12 months and has just delivered some really amazing and useful analyses for the government and for the response. One of the benefits is that the modelling can show you the probability that things are going to go wrong, or the probability that different strategies are going to succeed. And what's been really great about working with the department has been that they've fully understood the model, and they've been asking us questions that are really useful questions to be answered by modelling. And to give an example, they might have a couple of different policy options that they're considering, and those options would be a genuine tie. They don't know which ones to do, and from an epidemiological perspective, they're both good choices. And what we can do is we can simulate both of those options in the model, and we can tell them the probability that either of those options would succeed. And they would come to us for that sort of information. And particularly in circumstances when they're sitting on the fence, that's really valuable information to know. Not just we think it's got a high chance of succeeding, but this strategy has an X% chance of succeeding, and this strategy has a Y% chance of succeeding. So then, and I am now allowed to show you this, but here's some stuff that you probably wouldn't have seen, but this is the lockdown we're in at the moment. And we see that the blue, so these are cumulative COVID diagnoses in the recent outbreak. The blue is the trajectory we're on, and the red is what might have happened if we just had work from home and mask wearing, and they were the only restrictions. And the thing that gets me about this graph as well is that we do all this complex modelling, and you can see the uncertainty. The result is basically anything could happen. But the real benefit of it is that you can see from the density of it, which is the things that are more likely to happen. And so I think had we not had a response, things were not looking fantastic. And we've also got versions of this for different levels of response. So if we just had density limits and some restrictions, things look a bit better, but still going up. And if we closed some sectors, but we still allowed social gatherings, things would be better. And then there was more probability of success, but certainly not as much as the strategy that was taken. So I just want to end by thanking a whole lot of people. So firstly, thank everyone in the modelling team. Just, it's been amazing to work with you all over the years, and thanks for all of the great work that you do. And I think it wouldn't be as enjoyable a job if you weren't here doing it with me as well. Thanks to Margaret, David, Paul and Mark for just having my back over the years. So I just really appreciate that. And thanks, Liz, for just making sure that the wheels are always on the wagon. And not on the screen, but thanks to everyone else who I've worked with. There's too many people to name because I think I've worked with almost everyone at the Institute at some point or another, and some more than others. And I just want to say thanks. I've really enjoyed working with all of you over the years.